as for many. So this evening's event, the Hellenic Medical Society of New York Scholarship Symposium and Awards, is a true celebration of medicine in the Hippocratic tradition. Tonight, we honor practitioners of the art for excellence in academia and in healthcare delivery. Tonight, we support our colleagues in training for merit. Tonight, we encourage students who are considering the arduous path of service to IHEA. And most importantly, tonight we acknowledge the participation of patients in their care in partnership with their physician. Our distinguished honorees and our panel of speakers are assembled, and Dr. Tessaris is going to introduce the group. Our scholarship recipients are present. The patient will be heard. And I wish to express our society's gratitude and my congratulations to all the participants this evening, but most importantly to Dr. Theo Dictaven and to Dr. Michael Michelis for their effort on the awards committee and their efforts on the awards committee over many years. And it is through contributions such as theirs that the Hellenic Medical Society of New York has arrived at its 75th anniversary with such vitality and promise for the future. So, ladies and gentlemen, I would like to join you now in applause for this evening's program participants. And before I invite Dr. Tessaris to start this evening's program, I would also like to acknowledge Dr. Stanley Chang from the Department of Endocrinology, the chairman at Columbia University. The society has been in the position this year through a gift in honor of Dr. George Stambakis to offer a full fellowship in ophthalmology to Columbia University, the Harkness Eye Institute. It's a 2-year fellowship, 1 year of clinical work and 1 year of research in order to put the individual on a trajectory for an academic career. And hopefully we'll see them either to become distinguished Hellenes or to become distinguished Philhellenes, because this will be an individual of merit who will be the recipient of the scholarship. Also, I would like to acknowledge a gift from the family of Mr. Kartofilis. Specifically, we have, this is Aristia Angelopoulos, who is putting forth the award of $20,000 for a fellowship, in memory of Mr. Kartofilis, who over many years was a supporter of the society, a very good friend for many of us. We remember him very fondly. And this particular scholarship award, this is just one portion of it, which is being given by the family, is something which will, again, augment our funds and support us. And again, it comes at a difficult period because, as you know, medicine is going through a crisis, not because we as physicians have any problems, but because society and the illnesses that it has brought upon itself through lifestyle are such that great demands and strains are placed upon the system, and the system in its, great wisdom has elected to create barriers both for physicians and for patients in healthcare delivery, which are really not serving the process, and that has discouraged many of our younger, perhaps future colleagues, in their decisions vis-a-vis medicine. So we're out to offer them a message, a very positive message this evening. We have a very positive, optimistic outlook for medicine because it truly is a calling. And if you view it as such, I think it is the most noble of choices to be made. But again, I will let our speakers this evening illustrate what I had to say. And I would like to offer and invite Dr. Tessaris to now come to the podium.
Before I introduce the speakers, I'd like to say that I've come out of the cobwebs of retirement to see friends and colleagues, and I'm honored to be here at the request of Nick Mazides, and I really appreciate you calling me and having me come back to share this This is the 29th Medical Symposium on the 75th anniversary of the Society. It's a little more eclectic than the previous ones. The previous symposium on the nervous system dealt with Parkinson's disease, in which we honored George Kotzias. Many of you remember him. He was a innovator and great research scientist who developed L-DOPA in the management of that disease. The second symposium was on stroke, in which we incorporated many disciplines in the neurosurgical and neurological area, and it was very successful. And the third symposium was on Alzheimer's disease, and I chaired all three of those, and tonight I'm honored to again chair this series of talks by these distinguished neurologists and neurosurgeons. The first speaker tonight is the chairman of the Director of Neurosurgery at NYU Langone Medical Center. He's John G. Colfinos, and he's assumed that position in the retirement of a very distinguished neurosurgeon named Patrick Kelly in 2009, sorry. That's how far back I go. Dr. Golfinos' clinical interests and practice are limited to brain tumors and skull-based tumors, especially in patients who have this condition called neurofibromatosis 2. His current research interests include MRI tracking of single cells in glioma and metastatic melanoma, as well as clinical outcomes of radiosurgery for brain metastases. He continues to investigate outcomes of both microsurgery and radiosurgery for vestibular schwannomas. These are tumors that originate from the 8th cranial nerve and affect primarily the vestibular part of that nerve. In 2010, Dr. Golfinos became the president of the New York Society of Neurosurgery. In brief, this condition of neurofibromatosis 2 is also called Misby syndrome because it involves multiple inherited schwannomas, meningiomas, and ependymomas. And it is an inherited disease, usually an autosomal dominant trait. Its manifestation is the development of what we call non-malignant brain tumors in the region of the 8th cranial nerve, which is, as I mentioned, the auditory vestibular nerve that transmits sensory information from the inner ear to the brain. Most people with this condition also experience problems in their eyes. And apparently, what they really have problems with is they develop cataracts and they frequently need operations to correct their vision. I'm sure Dr. Golfinos will touch on this disease in more depth. There is no therapy to date for the underlying cellular dysfunction caused by this inherited disease, which is due to a genetic mutation of chromosome 22. I'm sure Dr. Golfinos will shed more light on this particular aspect of the disease. And I welcome him to the podium. Thank you.
Well, thank you very much, Dr. Soyce, for that wonderful introduction. I actually can tell you that you have no idea really how pleased I am to be here. Because I am a first-generation American. I was born here. Both of my parents were born in Greece. Actually, at the time that my parents came here, my mother went to Teachers College at Columbia, and it was a time where the current philosophy was one of assimilation for foreigners. So they spoke English at home, and as a result of that, I learned neither Greek nor English from my parents. But we did spend a lot of time in Greece. I learned Greek from my grandparents, actually. So once I get going, I'm okay. But I'm going to do this in English. So that's our little shop on the East River. They keep threatening to build a new hospital. And in fact, they're going to do that. It's supposed to open in 2017. They're going to put the shovel in the ground in 2014, they tell us. They've raised over $1 billion for the new hospital. One of the exciting things that I can do is we're actually planning the new operating rooms and all the new equipment and the new technology that goes into that. And in imagine trying to plan 7 years ahead of time what technology you're going to put in your operating room. It's a great challenge. Next slide. So I'm also very pleased that this is the 75th anniversary. It's a very special event for me. Next slide. I have no disclosures, just to say I do receive an honorarium / pittance, and I do need pittance from Medtronic in connection with their skull-base course. It costs me more to fly down there than they pay me to do this. And that's our AANS disclosure, which also stands for Archers Association of Nova Scotia. Next one. And the Australian Army Nurses Society. But it's really the AANS. Next. I can't give this talk without mentioning my collaborators, because as you'll see later in the talk, this really is a team effort, this disease. Tom Rowland has been my running partner for 15 years. He's now the chairman of ENT at NYU. We both started out as assistant professors at NYU, and now Tom is the chair of ENT and I'm the chair of neurosurgery. And without him, none of this would be possible. It's just a great teamwork, and really to tackle this disease, you need a team. Jessica Shafrick has been my nurse practitioner for more than 10 years, and she's the one who keeps everything running on time. And then these individuals are the ones who help us run the NF2 Center at NYU. Jeff Allen is a pediatric neuro-oncologist. Alan Rubenstein, same thing. And then you'll notice this name. This is Matthias Karagiannis. He has no idea how to spell his last name because he speaks German. He's from Germany. His father is from Greece also, but he speaks far less Greek than I do, actually. If I can see farther, it's really because I do stand on the shoulders of giants. This is Robert Spetzler, who was the chair of the program where I trained in Phoenix at the Barrow Neurologic Institute. Still one of the great neurosurgeons of our time. And Patrick Kelly was my predecessor, also one of the great neurosurgeons of our time. He's retired now and is sailing his boat. But I would say I have to give acknowledgement to two other people, which is obviously my mother and father. My mother will be there tomorrow night. My father passed away about a year and a half ago. Next slide. And I think there might be some people in the room who actually knew him. This is Argyros Kopinos. He was a cardiologist who was in private practice on the west side. He was at joint diseases for a very long time. And I can't think of a single time in my life where he told me that I had to be a doctor, but in a very Greek family way. It was clear that if I became a doctor, he'd be very happy about that. This is his Hellenic Medical Society membership card. This is from 1971, and that is from 1984. Next. That's his diploma from the Panepistimion Athinon. He graduated at Arista with highest honors. Next one, and this was, of course, back in the time of King Pavlos. Just pay attention to the way our last name is spelled in Greek. That will come back later. It's a gamma kappa. It's a diphthong at the beginning, so it really is Golfinos. Next. I'm going to give you because it's not a neurosurgical crowd, I'll give you the take-home lessons up front, and then you can take a break or you can listen for the rest of the story. But the point is that NF2, neurofibromatosis type 2, which we'll call NF2, is really one of the most complex neurologic disease entities out there because it affects the entire nervous system. And it's also the prototype for a disease that requires treatment in a dedicated center. In the past, neurosurgeons used to think that they could tackle this one at a time and it would be okay. But as time has gone by, it's clear that you really need a whole, it takes a village really to treat these patients. And the other thing that's so interesting about it, as Dr. Cyrus mentions, is that the story of NF2 is really the story of benign tumor growth. Everyone in this audience is more used to the story of malignant tumor growth. And it's rare to see malignant degeneration in NF2. Now, we've gotten so good at this that now the patients live long enough that some of them do finally undergo malignant degeneration. But really, it's a story of benign tumor growth. And my thought has always been that if we can learn to control benign tumor growth, perhaps it'll shed some light on how to control malignant tumor growth. It's a much simpler problem than trying to cure cancer outright. Next. I put up a few slides that show the top 10 traps. It's really for neurosurgeons, but I put this up to show you the complexity of this disease. These are all the things that can go wrong in NF2. You can make the wrong diagnosis and think you're dealing with NF2 when you're not. You can underestimate how difficult these schwannomas are on the vestibular nerve. You can overestimate your ability to save someone's hearing. It turns out to be extremely difficult. You can underestimate how hard it is to save someone's facial nerve function, so that you can generate people who have bilateral facial palsies, which is perhaps one of the worst neurologic deficits you can have. You can't eat very easily with the bilateral facial palsy. You tend to drool all the time. And you have to be aware that there can be multiple tumors. Next. It also involves lower cranial nerve schwannomas, so that they can have trouble swallowing afterwards. They can have trouble managing their airway. And the point is that you can't think of this as one operation. You always have to plan for the next operation if it happens. So everything has to be MRI compatible. You have to be very careful with how you manage the skin, and you have to be able to approach patients and the brain from every possible angle, so it really requires a skull-based training. And it turns out that it's not the arteries that are a problem, but it's really the veins and the venous sinuses of the brain. These patients have so many operations and so many tumors that intracranial volume becomes precious. They always end up with running out of room in the head from all the operations that they've had. Next. And then there's this lure of radiation. So one of the things that we're known for at NYU is the Gamma Knife Center, which is stereotactic radiosurgery, and I was the one who started it back in 1997, actually. But we don't even use it in NF2, and I'll tell you why later on. And that's been a trap for a lot of people, thinking that they can treat these tumors with radiation. And the other trap is lack of comprehensive care. So it really requires a center, requires careful follow-up of these patients, a clinical coordinator, and more importantly, so many of these patients are deaf, since it's the hallmark of the disease. And so they communicate by email. And this is, you really have to be proficient at getting to them and being comfortable with communicating by email for them. Next. We touched on, Dr. Tsaris mentioned this in the introduction a little bit. This is just to clear your mind of which is which, and this is important. Neurofibromatosis covers all of the neurocutaneous syndromes, the phacomatoses. We're going to use Greek words all night, of course, as always. And it is an autosomal dominance inheritance, but it's also the classic disease for loss of a tumor suppressor function. So these people are born lacking a gene that normally turns off tumor growth, and then when they get a second hit on the other normal gene, they lose that function. They can no longer stop the growth of these tumors. And all of these tumors arise from neural crest cells. That includes melanocytes, these endoneurial fibroblasts, and especially the Schwann cells. NF1 is an entirely different disease, even though it's one of the phacomatoses. It's a different gene. This is what's known as von Recklinghausen's disease, or elephant man disease. It's on a different chromosome. It's on 17, on the long arm of 17. NF2 is the one we're talking about tonight. It affects about 1 in 25,000. And the gene that's mutated is on long arm of chromosome 22. And the gene that gets knocked out produces a protein that's called Merlin. And the hallmark of the disease is bilateral acoustic neuromas. Schwannomatosis is a recently identified disease. It's even more rare than the two of these. Also note that NF1 is about 10 times more common than NF2. The candidate gene here is NE1. But so little is known about this disease. This is what we're still trying to accumulate information on. And there's an overlap even between all three of these, especially between these two. But the one we're talking about tonight is this. One of the things I've had the pleasure of directing as chairman of my department is deciding what our strategy is going to be. And one of the things we want to be great at is a few rare diseases. NF2 fits into that. We also have a nationally known tuberous sclerosis center. And why is that? Because we feel that those need to be done in big centers. And we have the surgical expertise to handle these challenging diseases. So we think that we can make a real contribution by concentrating on rare diseases that otherwise are not worth other people's time, to tell you the truth. So much more money goes into NF1 research because, again, it's 10 times more common than NF2. But we're trying to direct money and research into this area next. What happens if NF2 gene gets knocked out? It's actually not limited to the classic disease called NF2. You see NF2 gene inactivation in mesothelioma. You see it in melanoma, renal cell carcinomas, even in colorectal cancer. And, of course, in all these other brain tumors, you can see it. Very common in meningiomas, very common in sporadic schwannomas in people who don't have the inherited disease. Very common to see NF2 gene function knocked out as well. Next. And this is the disease. You'll notice this is a small little cafe au lait spot on the skin. So these are really part of NF1. They happen in NF2, but are not that big part of the disease. The real thing is up here. Hearing loss and deafness is a hallmark of the disease because of the bilateral tumors on the hearing nerve. You also see meningiomas as a big part of this, cataracts at a young age. Next. And that's just to spell it out in our minds so we get them both straight. NF1 is the disease that you think of as elephant's man's disease. Cafe au lait spots, the big neurofibromas that grow out of the skin. This is the visually obvious one. It's really a tumor of kids, and the real problem in NF1 is they grow up with developmental delay, or more, they grow up with these subtle neurological developmental delays, such as ADD or other diseases like that. So this is really a pediatric disease, and it's really about neuropsychologic support. It's not much of a surgical disease. Next. NF2 is a surgical disease, and mostly because of these tumors, trying to get them out before they cost the patient their hearing. It's also because of these meningiomas that grow and cause problems, even the subcutaneous schwannomas, and even the schwannomas that grow on the spinal nerves and all over the spinal cord. You do see cafe au lait spots, as I just showed you, but it's not a hallmark of the disease. And you do see these cataract-type malformations. Next. This is how you make the diagnosis. You have to fit in this. If you have bilateral vestibular schwannomas, it fits the modified NF2 criteria for the diagnosis. Or if you have a first-degree relative with NF2 and you have one, or any two of these, or if you do have a vestibular schwannoma on one side and you have two of these other things, any other two meningiomas, it fits the criteria for NF2. And that's because it got confusing in the beginning. It was clear that anybody that had vestibular schwannomas on both sides, I still use the old term acoustic neuroma, clearly has this disease. But we ran into all these other patients that had only only one acoustic neuroma, but all these other meningiomas, and they fit the disease as well. Next. This is a picture of it, so you can see it. This is an MRI scan viewed from the side, of course, a sagittal image of the lower spine. All of these white dots are the tumors on the nerve roots, all of these little things here. And you can see what happens at the top of the spinal cord. This is probably a meningioma right outside the cord there. This is a meningioma on the back of the cord. This one looks like it's in the cord, or else it's a spinal root tumor. This is a big meningioma, the tuberculum cellum, a meningioma hanging down from the tentorium. So these are tumors up and down the nervous system, and this is why it's such a devastating disease to the patients. Next. What about prognosis? So the important thing to realize is that the age at diagnosis is the strongest predictor of mortality in NF2. But these are also three independent predictors of mortality: the presence of meningiomas in the head, the type of treatment center, and the degree of mutation of the gene, or the type of mutation of the gene. Thanks. And this shows that this is for patients who have the age, the age of diagnosis is over the age of 20. These are ones who are diagnosed in childhood. And you can see that half of these people have succumbed by the age of 40 if they're diagnosed by the age of 20. So it's a much more, it's not gentle, but it's a much more indolent disease if you're diagnosed in adulthood. Next. And that probably, or almost certainly, reflects the type of mutation that you have in the gene. What about these acoustic neuromas? One thing that's clear, their growth rate is highly variable, and it is also true that they actually stop growing as you get older. So if you can survive into late adulthood with these diseases, you can usually preserve your hearing because the tumors slow down their growth. Next. What about this hearing preservation? Well, it's really difficult. That's sort of the take-home lesson. In the old days, which was 20 years ago, we used to think as neurosurgeons that we could take these tumors out and save the hearing, and we could do it once or twice. And like all surgeons, we forget that the 18 times when we didn't do it and remember the 2 times when we did. The early resection tends to hearing. So the only way you can get away with it is if you can catch them when they're really small. And usually that's when you have a family cohort. You investigate other family members and you find small tumors that are less than 10 millimeters. Then you have a chance of taking them out and preserving the hearing. And this creates one of the most difficult problems in neurosurgery when you're tempted to operate on a patient that has a single side hearing ear. So they've already lost hearing on one side, and you're going to try and take out a tumor to save their hearing in the other ear. But if you fail at it, you're going to make them deaf on the day of surgery. So we really moved more to conservative management in patients who've already lost the hearing on one side until the hearing is completely lost. Sometimes you just don't have a choice, and then if the hearing is lost, I'm going to talk about this, we put in one of the first FDA-approved brain interfaces, mechanical brain interfaces. That's an auditory brainstem implant. Next. This is what the disease looks like in the head. This is one of our patients, a 28-year-old male who lost his hearing on the left side from this tumor and lost his facial nerve on the right side from this tumor, so the right face was paralyzed. We took out this tumor on the left. That's a fat packing. We put in a big fat graft to seal off the hole. You can see the tumor is gone, but the other side tumor, of course, is still there. And we left that in because he still had hearing on the right side. No way to take that tumor out and save his hearing. Next. So he went on to lose the hearing because of this. This is on a drug trial, on one of our drugs that we gave him, and it seemed to make the tumor grow faster. And again, then we were forced to operate on that side. He had lost his hearing by the time he got in there. You can see the real extent of his tumor. It's massive. And this is after we take it out, and you can see the brainstem just starting to re-expand here. Next. Next. Thanks. So this is a key thing to follow. We do it every 6 months in our center so that patients get an MRI scan every 6 months, because those 2 MRI scans you saw there were less than 6 months apart in that patient. These tumors can take off. And we also do the spine. Now we've gone to doing the spine once a year. How often you do this is very controversial. In the UK healthcare system, they get a CAT scan only every 2 years, which really seems inadequate. This means you're just going to pick up the big tumors usually when it's too late. But again, it's a function of the healthcare system in which you are located. Next. And what about the meningiomas? Why is it such a crucial tumor in this disease? Because it can dominate the late phases of the disease. The patients now live long enough that the meningiomas can creep all over the brain and eventually lead to their demise. And these are different tumors than the meningiomas that show up in normal people who don't have NF2. They're much more aggressive. There's more challenging surgical management, and they can take off after periods of little or no growth. The presence of intracranial meningiomas, as we mentioned before, is an independent predictor of survival. Half of all these patients have meningiomas in the head. And now that we've gotten so good at the other skull-based tumors, we can see patients where the meningioma grows over the whole brain at the end. And the other thing about these is they are aggressive. Almost half of the tumors taken out that are meningiomas are actually atypical meningiomas. A full 11% are anaplastic. The old name for this is malignant meningioma. So these are really difficult tumors. So our treatment strategy is really, we only treat symptomatic tumors, and that includes the ones that show a lot of edema or mass effect. We call that radiologically symptomatic. And we're always cognizant of the venous anatomy and how the brain is going to be able to drain itself after we take out this large tumor. Next. And this shows you another typical case. This is how old is this gentleman? 46 years old with a small tumor here. It looks like that's going to be pretty easy to handle. You can see his other meningioma back here. Next. But that's only half the story. To get to this meningioma, that's the same meningioma seen from the side. You can see his nose here and the back of the head here. To get to this, we have to go through this. This bone is clearly abnormal. He's got a lump on his head, and that's all from meningioma involvement of the bone and even under the subcutaneous tissues. So next. And this is what his veins look like. There's normally a large draining vein over the top of the brain that's already gone in this patient. So he's draining through all these little squiggly veins that drain down through the skull base. And this is all a trap for you. If you don't pay attention to these, you can create a venous stroke. Next. And that's what it looks like before and then after. Taking it out. This, of course, will be the next shoe to drop. We're going to have to deal with this eventually. Next. And again, before and then after, you can see we put in a titanium mesh here to cover it. He went to do yoga about a year later and actually managed to put a dent in this from standing on his head. Never seen it before. We called the manufacturer. They'd never seen it before. But that's what he did. Next. This is the same thing. You have to choose the right way to get in here. Here's another very large meningioma. You can see the other ones around it. And you can see how we come in from the back to take that out with a little harm. Next. And again, another one. This is that same gentleman you saw before with the two huge tumors. This was his bone. Again, another horn on the head. We had to take that out and put it in a mesh. Next. So what about it? If these are such difficult tumors to deal with surgically, why don't we just take them and why don't we just radiate them? Because this is a disease where people can't stop the growth of tumors. So when you radiate them, you increase the risk of malignancy. And remember I said at the beginning that the malignancy in NF2 is usually not seen unless you radiate them. So this is at least one paper. This is from the group in England. Gareth Evans, a good friend we work with, and that we've collaborated with, and it shows that there's a much higher risk for malignant transformation in these benign disease states, again because they lack a tumor suppressor gene. Next. So we don't consider it an option. And here's the other reason. Here's a paper that's in favor of radiation from Jeremy Rowe. And you can see that they said they had 50% control at 8 years follow. Well, to me, that's 50% progression at 8 years follow. And unfortunately, we're the ones who have to deal with the failures after radiation. So it doesn't help us if someone's been previously radiated. In fact, it hurts us if we have to deal with that tumor. And if half of them are going to grow within 8 years anyway, we really not radiate them. We not prefer to radiate them, rather just operate on them. Next. And this is from the Princess Margaret, just to drive the point home, Princess Margaret University of Toronto. You may not be able to see it from the back of the room, but these are all acoustic neuromas in the setting of NF2 that became malignant nerve sheath tumors after radiation. Next. And again, just another 13 more cases in NF2 patients with malignant transformation. Next. So the other problem is that it doesn't really preserve their hearing, so you're not getting anything good out of it. And it has those very poor control rates. And again, these are patients who lack a tumor suppressor gene that you're radiating, and we think it makes poor results with the auditory brainstem implant, and it makes it very hard for us to save the facial nerve if we do go to surgery to take that tumor out when it fails. Next. And this is sort of the end stage of the disease. This is all meningioma, all the way over the top of the brain and all the way down the other side. The entire brain is caked in meningioma. And that's the other problem with radiosurgery. This isn't a focal disease, it's everywhere. It's in the entire nervous system. Next. So I do want to say, just I have a few more minutes, just say a couple of things about auditory brainstem implants, because it is exciting. It's actually trying to restore hearing to patients using a mechanical device, using an electric implant. Next. And this is it. This is a paddle that has electrodes on it that we actually insert into the brain. This is what it looks like. And then it's connected by a long wire to this receiver. The receiver gets connected through this to a processor. This is a microphone. Sound comes in the microphone, goes to the processor, and then gets distributed by this wire to these paddles and actually stimulates the dorsal cochlear nucleus according to the pitch and frequency. Next. So this is where we put it. This is actually a view of the patient if you imagine lying on their side. It's the left ear, the right ear, so that the top of the head is over here. We're looking behind the ear like this. So the bottom of the legs would be out this way. The back of the head is over here. The ear would be right here. And we put the ear up. We open the brain up. This is the flocculus of the cerebellum. And this is the stump of where the eighth nerve used to be. That's the actual brainstem there. And we slide this paddle in right over the stump of the eighth nerve into the brainstem towards the fourth ventricle. Next. And that's what it looks like with this paddle in there. It's got the electrodes on it touching the brainstem and the wire coming out. So they are literally wired for sound. And then that comes, and then after they heal up, the incision was back here. After they heal up, they use this to communicate with the device. And again, they wear this microphone that gathers sound, puts it to the processor, and then sends it into the brain to stimulate the brain to give the perception of sound. And what does it actually do? Well, most of these people are deaf when we put it in, so they, unless they're recently deaf, they become pretty good lip readers. So in blue, this is what they look like when they just have vision. But when you turn on the implant, you can see how much better they get at getting words right. These are City University of New York sentences, so they can get up to 60% of the sentence right once you turn the processor on, whereas before that they only got 30% of it right. Are there any side effects to it? Yeah, you're stimulating the brainstem. So sometimes you get facial nerve stimulation, they get a twitch. This one they put it down here as a throat tingle or tickle. That's really a choking sensation, which the patients, of course, don't find acceptable. But generally the side effects are very low. Next. And what does it sound like? Well, those who still have memory of hearing, because this was only recently approved, there are people who made it into their 30s or 40s who had lost their hearing 20 years before, but those who still had good auditory memory say that it sounds like the lightsabers in Star Wars or the voice of Charlie Brown's teacher. Thanks. And then when you ask them, would you recommend the auditory brainstem implant to others, 74% said they would, 83% say they get benefit from the ABI, and 86% think that their decision to get it was the right one. This is a group that we got involved in through the Children's Tumor Foundation, which is one of the primary funding sources for NF2. You can see that this is a multi-institutional thing. These people are from Manchester, England. This is another good Greek. Michelle Kalamaridis is in Paris. Also doesn't speak a word of Greek. This is our group here. And again, with Matthias Karianis, also from NYU. This is Roger Packard down in Washington, D.C. This is Ohio State. These are the guys at House Ear Institute. This is Cornell. So it's a multi-institutional collaboration to deal with this. Next. And the point of this was, if we're doing so badly with surgery and with radiation, how about medicine? So that's what we tried. Next. And this came up through a trial that was done in Boston at MGH. And they were using bevacizumab to treat the tumors. And they actually had people whose hearing recovered. It came back up while they were on bevacizumab, otherwise known as Avastin. So their hearing improved. Unfortunately, the improvement wasn't lasting, and the tumors began to grow again. Next. So the Children's Tumor Foundation brought us all together in a room. We wrote that paper, the consensus statement, and the idea was to find the next drug. And we came up with a patent, which you may know as a Tykerb used in breast cancer. We did both a phase 0 and a phase 2 trial. Phase 0 is fascinating. Next. Again, this is Matthias who ran the trial. Next. The idea behind the phase 0 is we got 26 patients with acoustic neuromas, 13 who had NF2 and 13 who did not. And they were all scheduled for surgery because they needed it. And they all took lapatinib, or the experimental arm took lapatinib for 10 days prior to surgery. Control group took no drug. So out of the 26, 20 people got drug. That includes people who had regular old acoustic neuromas, did not have NF2. These people are my heroes. When you ask them why they did it, they say they feel like they owe it to their fellow human being, and they felt like it was something they had to do to help other people. So they actually took a chemotherapeutic drug just for the sake of the trial. Now, granted, it's lapatinib, there's few side effects, and it was only for 10 days, but it's still a big deal to me. And then they all went through surgery, and we just did one this week. And I'm sitting there in surgery, Matthias Karianis comes into the room, the other Greek, he takes out his little sterile tube, and I actually take samples of the tumor and drop it in the tube for him. And the idea is to measure whether or not the lapatinib gets in, and if it does get in, is it doing what it's supposed to do? Next. So that trial is still ongoing. We also, because the patients were so anxious for some treatment, we also started a phase 2 trial where patients who had NF2 and clearly had a progressive tumor could then go on medication in an attempt to preserve their hearing. And if they progressed, then we took them off and tried something else, usually Avastin, and this trial is still ongoing also. Next. And then this will be the next thing. Everolimus is one of those immune suppressive drugs, but they all operate on the mammalian targeted rapamycin gene, the mTOR pathway. It's another oral drug, and it works in tuberous sclerosis. This is actually the disease, tuberous sclerosis, where these subependymal giant cell astrocytomas shrink in response to RAD001. So it's being tried in NF2. You can see that we said we were going to open in October. There's a drug shortage. Why? Because these are orphan diseases. It's hard to make money treating tuberous sclerosis and NF2. So there's currently Novartis is limiting the release of the drug, but hopefully that's going to get going next. And that's where we're going to go. These are other drugs that we may use. We're going to try putting Avastin in intra-arterially directly into the tumor next. And that brings us to sort of the end. And the point of this is that we can do these because we put together this dedicated center that includes all kinds of clinicians, ENT surgeons, neurosurgeons like myself who do the brain. I have different neurosurgeons in my department who only do the spine tumors, peripheral nerve tumor surgeons, everybody, orthopedists. It takes a lot of people to do this, and it enables careful follow-up. And it's very difficult to do that on your own. This is what the center looks like, the NF2 patient in the middle of everything. This is probably the most important person. It's a nurse practitioner who stays in constant contact with the patient and helps them get through the cycle. Clinical trials, surgical care, we have a very active tumor bank, which is also critical, so we can preserve all of these specimens for the patient. And then, of course, we send them to the basic scientists next. And so that's saying it again in the same way. And internet communication is vital. I can tell you that these are extremely eloquent patients who are trapped only by their malfunctioning cranial nerves. You look at them and you think that they look developmentally delayed, they have trouble talking, they've been deaf for 20 years, you can hardly understand them. But if you get them on email, it's unbelievable how preserved their neurologic functioning really is, and these are extremely eloquent people who are just looking for help. Next. So in summary, next. Follow-up is everything. Avoid the traps that I mentioned. And hopefully someday we'll be able to say, take two Lapatinib and call me in the morning. Next. So I just want to finish up with one thing, and that is the question, what kind of name is Golfinos? I mentioned this in the beginning. Next. So, Crete, right? My father's from Akrata, a tiny little town in the north of Greece, right along the north edge of the Peloponnesus, the first of his family to go to high school, let alone medical school, let alone come to the United States and be a doctor. His brother was actually left-handed, never learned to read because they tied his left hand behind his back. That's true. This is my uncle Andreas. But the point is, so when you ask my father, he said it was Golfos from the religious medallion, that the Golfinos must have made Golfos. That's how it was. But there really is no G in Greek, not the hard sound in Golfinos. There's that diphthong, right? And there's Lama, but that's not it. It's not Golfinos. It's Golfinos. Next. So it's spelled with the diphthong, Gamma Kappa. Next. And so the question is, maybe the name really is Golfinos, which is a Galician word really for dolphins or fishermen. Next. How could that be? Well, in 1571, the Battle of Lepanto was an important event. The Turks were sweeping across the Mediterranean from the east. They left from Lepanto with their massive fleet, and to meet them next was the Holy League. Western Europe was desperate to stop them, so they put together a massive armada in 1571, and the ground zero was going to be the Mediterranean. The only thing they had on their side is they had the massively rich Venetians and the Genoese, who introduced the first battleships, massive ships that had enormous numbers of cannons on them that no one had ever seen before. And they'd bring these into the battle, turn them sideways, and it turned the tide of the war because they were against a very, very talented Aga Khan, and they managed to win this. Now the question is, where was that battle fought next? And the Holy League was Venice, Genoa, Spain, Portugal, France, and Little Galicia next. And the battle was fought in the Bay of Patras, which is right here. This is my father's hometown, Akrata. Next. So perhaps Golfinos really is a Galician name from the 16th century, from sailors who stayed behind in the beautiful Greek lands after the Battle of Lepanto. So I just want to say thank you again for this wonderful opportunity to present here, and I really can't say much.
Little as you know, the people from Scotland migrated to Greece since they discovered golf, so they added Kinos to golf. It became Golfinos. Hope you're a golfer. Anyway, our next speaker, again, is a distinguished neurologist in New York who is going to talk about another uncommon neurologic disease called neuromyelitis optica, which is synonymous to Vick's disease. This is an uncommon disease of the nervous system that affects the optic nerves and spinal cord. Simplistically, for non-medical people here, the people who are diagnosed with this disease experience a rapid onset of blindness in one or both eyes, followed actually within days or a few weeks with varying degrees of paralysis in their limbs, sensory disturbances, and sometimes incontinence of bladder or bowel. And this is where the term transverse myelitis comes in. More common in women, and I'm sure further light on the subject will be touched upon by Dr. Darris, who is our speaker on this subject. Dr. Darris graduated from Athens Medical School in 1969 and served in the Greek Air Force thereafter, and came to the United States and did a neurology residency at New York Medical College and a fellowship at Albert Einstein, with an old friend and colleague of mine, Dr. Al Spira. He subsequently joined the faculty at New York Medical College, and became the chief of service in neurology at Metropolitan Hospital from 1997 or 87, I think, until August of 2000, and now has joined the faculty at Columbia University Neurological Institute and is there a clinical professor of neurology. I welcome Dr. Darris.
Thank you for inviting me. It's a great pleasure and honor to be here tonight. Before I start, Dr. Golfinas would have made my wife very happy because he mentioned Lepanto and Nafpantos, where her parents are from. But she's not here. She's taking care of our granddaughter and everything. So, when Dr. Lazidis asked me to talk and asked me to choose a subject, I told him that my interest is mainly in the history of medicine as I'm getting older. He said, no, I want something modern. So we'll talk about something modern, but I'm going to sort of give a history of the whole subject and how our concept of a rare disease that started years ago has evolved over time with the development of new technologies. The first person, and you cannot make fun of his name, was Sir Thomas Clifford Allbutt, who first described the first case in which a patient developed myelitis and an optic nerve disorder. But 10 years later, Wilhelm Erhard in Germany published again another paper, again about optic neuritis and myelitis subacute. And 11 years later, Aoyama in Japan described a similar case. It was not until 3 years later, in 1894, when Eugène de Vic in France, supervising his student, Fernand Gault, described 17 patients. They were part of the thesis of the younger neurologist, and then they were published by Dr. de Vic. And he described basically 17 patients who lost their vision in 1 or 2 eyes, and then they developed spastic weakness with loss of sensation and loss of bladder control. And at that time, they thought it was an inflammation of the optic nerve and the spinal cord. And they were not so bad about it. I mean, they were pretty accurate about this. Since then, the disease has been part of the whole spectrum of multiple sclerosis, or at least it was considered to be so. The hallmark of the disease is basically the optic neuritis, which is manifested by loss of vision, which may affect one or both eyes, usually both. And then it is also associated with the presence of acute or subacute myelitis, with complete or partial paralysis of usually below the neck. These two conditions may occur sort of isolated or in combination. They may occur at the same time, or they can occur separated by days, weeks, or even years sometimes. And in some of these cases, there were symptoms sometimes indicating that the central nervous system or the brainstem was involved. Again, the people had developed different kinds of criteria how to diagnose it, but still it was considered to be part of multiple sclerosis. We go to the next. There was, however, some distinct differences, both clinically and in the laboratory, that sort of started making people think whether this is the same or the different thing. First of all, the attacks of the NMO were much more severe than the attacks of multiple sclerosis. The blindness in patients with NMO may reach at least 50%, if not more. There were, this case is associated with a higher or very high incidence of death rate, frequently from respiratory failure. The spinal fluid picture in these patients was slightly different than that of the patients with multiple sclerosis. In a sense, there was pleocytosis. That means that there were cells, white cells in the spinal fluid. And what is the hallmark of MS? The oligoclonal bands were frequently absent. The other thing that is not uncommon in patients with neuromyelitis optica is the coexistence of other more systemic autoimmune conditions like the lupus erythematosus or the Sjögren's syndrome. As technology developed and we had MRIs available to us, one of the things that we noticed is that the MRI picture was not the same. Frequently, the brain was normal, but what was typical in patients with neuromyelitis optica was the picture that we see in the spinal cord. Even though in the initial reports everybody was talking about transverse myelitis, in the NMO cases, as we saw on the MRIs, the involvement was not transverse, but was rather longitudinal, and in almost all the cases included at least 3 or more levels. The optic neuritis, as we saw on the MRI, showed bilateral optic nerve involvement, and the chiasm was frequently affected. And one of the other things, particularly in cases with NMO who have an intractable hiccup, there was like a linear medullary periaqueductal involvement. Can we see the next one? And you can see, I don't have a pointer to show you.
It's up there,
Oh, here it is.
the middle button.
And you can see the involvement of the spinal cord that it's long, it's a longitudinal involvement and affects several levels. Can we go to the next one? By the way, this is the same patient after treatment, but you see that the lesion has almost completely disappeared. These are some of the lesions that we see in the brain. And again, the lesions, if they occur in the brain, they don't have the typical appearance that we have with MS, which is usually pericallosal, but it can involve other areas of the brain. But this, the area, as we see here along the aqueduct, is almost typical in these brainstem involvement cases of NMO. We get the next one. I mean, this is another picture of patients showing diffuse white matter involvement in the brain. Can we go to the next one? And again, these are some more cases involving, again, as you can see, the longitudinal. These are longitudinal, they're not transverse. And if you look at the transverse section, they involve mainly the central core of the spinal cord. Can we go to the next one? Again, as I mentioned before, people thought that these patients were nothing else but severe cases of MS. And then in 2004, Vanda Lennon and her group at the Mayo Clinic was able to identify an antibody in the IgG type that was present in patients with neuromyelitis optica. About a year later, she and her group were able to identify the antibody as being an IgG protein directed specifically against the alpha-porin 4, which is a water channel that we find in the brain, but also in other organs of the body, including the kidneys. And in subsequent studies, she was able to demonstrate that this is a fairly specific antibody that is present essentially in cases of neuromyelitis optica and absent in patients with multiple sclerosis. And by doing that, she was able to demonstrate that the NMO was not only a distinct condition from multiple sclerosis, it was not anymore like a generic autoimmune condition affecting the brain and the rest of the nervous system, like MS, where we don't know what the antibodies are. But she was able to demonstrate that it was a disease with a specific antibody targeting a specific protein in the human body. In subsequent studies, she was able also to demonstrate that the presence of these antibodies had also a prognostic value, in the sense that the high titer this antibody was associated with tendency for recurrence or relapse of the condition. Can we get the... And this is part of one of the articles that she published. One of the interesting things also is that in the patients who had other autoimmune conditions like lupus erythematosus or Sjögren's syndrome, there was sort of a comparison study trying to find out if those who have neuromyelitis optica with lupus or Sjögren versus those who did not have NMO but had lupus or Sjögren, where there was any correlation. And the interesting thing is that patients who had lupus or Sjögren, who had NMO, had very positive titers for the aquaporin 4 antibodies. So it's a specific antibody that is associated with specific syndromes. Now, what do we do? Let me go to the next one. With these patients. Again, since the number of these cases is extremely small, we don't have any large series. And nobody's actually interested in developing new treatments or new drugs for this condition. So we rely on our experience in treating other neurological autoimmune conditions or other rheumatological autoimmune conditions. And of course, the first treatment that was tried was steroids, and methylprednisolone in quite high doses for 3 to 5 days was associated with an improvement in these patients. Again, the response to treatment is not as good as the response of treatment in patients with acute idiopathic optic neuritis or optic neuritis related to MS. In some of the more severe cases for the acute treatment, plasmapheresis has been tried quite successfully again in small series with a small number of patients. And in some of the very severe cases, lymphocytopharesis has been also tried. IVIG for the acute treatment has not been very successful, but as I'll mention later, it has been tried in patients with relapses or recurrences. And we got the next one. Since this condition is a rather aggressive condition, much more aggressive than MS, and the residuals after the acute attack is over, if it is over, are very severe, with more pronounced sequelae and deficits than MS. It's very important to try to prevent the attacks. Okay, and in that sense, the presence of these antibodies has been extremely useful in sort of predicting the tendency for relapse. Traditionally, the oldest treatment available has been azathioprine. More recently, Cellcept or mycophenolate mofetil has been tried, which is a medication that we usually use in patients to suppress their immune system after transplantation. One of the most recent studies showed that rituximab, one of these monoclonal antibodies, that seem to become very popular in treating autoimmune conditions has been extremely useful. And again, our experience with mitoxantrone from MS seems to be paying for the same patients, for the patients with NMO. The problem with mitoxantrone is you can only use up to a certain amount of this medication for the patient's lifetime. And it is associated with severe potential side effects, particularly cardiac side effects. Some of the other treatments that have been used for this condition are, in some patients, low dose steroids for a long time has been useful. Cyclophosphamide has been useful, and intravenous immune globulin has been tried repeatedly over time in these patients. I think I gave a brief overview of the condition. And as I mentioned before, I like to talk about history, and history does not stop now. So in the next slide, I'm going to mention where the current research is trying to find new ways of attacking the condition. Eculizumab, another monoclonal antibody against the complement C5, is under study at the Mayo Clinic. The two proteins, the A proliferation inducing ligand and B cell activation factor for TNF family, is being tried in an attempt to stop the lymphocytes from producing antibodies against the aquaporin 4. And there is another research project, again I'm not sure if it's at the Mayo Clinic or somewhere else, trying to modulate the M23 isoform for the aquaporin to prevent or limit its being targeted by the aquaporin 4 antibody. And I think I'm going to stop here. And I hope I covered briefly a rather unusual condition that is sort of a condition associated with a lot of excitement, particularly among neuroimmunologists. Thank you.
The next talk will be the last one, and we'll accept questions for all of these speakers after this talk. Just as a sidelight, Vanda Lennon at the Mayo Clinic, who has been responsible for putting this disease on the map, was married to a gentleman who was also at the Mayo Clinic named Edward Lambert, who was one of the foremost clinical neurophysiologists in the world, who described Eaton-Lambert syndrome, which is a type of myasthenia gravis, but not exactly. It has a different physiology behind it. And I trained with him for 3 years, and he was my mentor and probably one of the greatest physiologists that I've known in my career. Vanda Lennon was married to him and was the immunologist in charge of the immunology lab at the Mayo Clinic when I was in training. Moving on to our last speaker, this is a different type of talk. It's moving from the central nervous system to the peripheral nervous system. And it deals with a clinical neurophysiological test that's used by neurologists, particularly neuromuscular specialists, in the diagnosis of neuromuscular diseases. Dr. Karidis is a board-certified neurologist with an MBA in healthcare administration and is actively involved in our society as an assistant treasurer, presumably, I think, to Andy Kosmanis, who I think is here. Who is the treasurer? Is Andy here? Hi, Andy. Didn't see you earlier. Excuse me. Dr. Karidis' background is basically doing a fellowship at the LSU Medical Center in Louisiana and studied electromyography this talk tonight is really to talk about how this test is used in the diagnosis of neuromuscular problems and what the indications are. And I'm sure he's going to give you a basic understanding of electromyography, which incorporates doing nerve conduction studies and needle examination of muscles. It's a two-part test. And I'm sure he'll give you an overview of how this test is helpful in diagnosing peripheral nervous system disorders. Michael? Or Demetrius? Right. Okay.
How do you do? Okay, so you can go to the next slide, please. Right. My aim tonight is to just give everybody an overview on, everybody's heard of this test, or most people in this room have heard of this test called an EMG, or nerve conduction studies. There are very different things said about the test. I just want to give you an understanding and overview of what the test is and how it should properly be used. The most important statement that I can make is that the test itself is not really, should not really be thought of as a test. Okay, the nerve conduction studies and the EMG, all right, so we'll just say EMG from now on for the whole thing. The EMG really should be used as an extension of the clinical exam. And that really means that the test has very limited use and can even be confusing unless the clinician brings the electrophysiologic findings back to the patient. What's often happening now is that the test is being used by many people for just reimbursement purposes and thinking that they can do the test and it doesn't matter how it's done, where it's done, but I hope to give you an understanding of just how the test is done, that maybe it really is just an extension of the exam. So to begin, no talk of the EMG nerve conduction study is really adequate unless we go over the anatomy a little bit. So I'm just going to assume that I'm talking to a non-medical audience here for this purpose, okay? And so that the nerves, the peripheral nervous system, the nerves that serve the arms and legs, basically, the nerves that serve the arms come out of the neck, and the nerves that serve the legs come out of the lower spine, as you can see here, if it's clear. And next slide, please. A more simplified version is like that. Next slide. And each nerve follows a particular pattern. And it's the clinician's job to know the particular pattern and combination of where the roots at each level go. So the nerves are named at each level that they come out, from C1 to C8, and the other ones have numbers in the thoracic level and the lumbar and even the spinal level. The same thing goes for motor function and sensory function. The sensory levels are called dermatomes, and the motor levels are called myotones. So this picture is an example of where the sensation from each nerve root level is served. Okay, we can go to the next slide. Now, I chose this picture because I think it illustrates very well, to give you a basic understanding of how the nerves run. They come out of the neck, but then over there, just outside the neck, they mix into something called the plexus, and then they go in their various different ways, all the way to the tips of the finger. Now, the nerve test is really based around this idea. We attach leads to selected areas where it's been worked out that that standard nerves and muscles run, And these are selected because the combination of findings can localize the particular root level, plexus, further out into different parts of the nerves in the arms or even in the fingers. Next slide, please. This is an example of how, all the doctors in the room have seen this picture before. This is the brachial plexus. Just after the nerves come out of the neck, they mix together into a knot, which is called the plexus, and then from there they run into 5 main nerves that serve the arm. Next slide, please. Okay, and this is a picture of the median nerve, which is involved in carpal tunnel. Carpal tunnel syndrome is caused by compression of the nerve as it crosses the wrist. It's very common, and there are various degrees. The purpose of the test is not only to show that they're slowing at the wrist, but to show how it's relevant in the person's case, because randomly you will find nerve slowing in many people. It's a very common finding, and it doesn't necessarily mean that the patient has carpal tunnel syndrome. As a syndrome, first, you go to the patient, and a syndrome is a combination of signs and symptoms. If there are no symptoms, there is no syndrome, and no technician or physician can or should diagnose carpal tunnel syndrome based on just the nerve conduction study findings alone, as is what's starting to be seen lately, which is really an abuse of the test. So next slide, please. Okay, just the same way that the nerves in the arms come out of the neck, the nerves that go to the legs come out of the lower back, and this is a representation of the way that pain travels. The pain is felt in the distribution of the nerve, and the red signs are trying to represent that. Next slide. Again, just like there's a brachial plexus in the arm, there's a lumbosacral plexus in the leg. Just outside the nerve roots, they mix together in a knot called the lumbosacral plexus, and they go out into the various nerves to different parts of the leg. Next slide. Okay, so now what I'd like to show you next is basically how the pinched nerves is what's called a radiculopathy, how this originates. Now, you remember the first slide where you saw all the nerves coming out of the different levels. Okay, as the nerves come out of the spine, they come out in certain holes that are formed between the two vertebral bodies. How they fit together, they form a hole called the foramen. The nerves exit at those holes, and there's a soft, hard jelly disc called the intravertebral disc that cushions the bones. So the spine is really formed, as you can see on the right side of the slide. The spine is really formed by these funny-shaped bones piled together in a column with the hard jelly disc cushioning them. What goes wrong is that this hard jelly disc can bulge out and pinch the nerve. So if you look at the next slide, this is the top view, what we call an axial section. The vertebral body, and at the same place over the vertebral body will be the disc. The spinal cord runs in between, and you can see the nerve roots exiting out on this axial view in between where it forms the hole into the roots. Now, if you see the next slide, this is an example of what happens. This is a representation of what happens when the disc bulges. We call that a herniated disc, and you can see it's pinching the nerve just as it's exiting the root. Now, the patient will feel wherever that nerve runs, the patient will feel pain or numbness going to the peripherally to wherever that nerve runs. And depending on how badly the nerve is pinched or how badly the nerve is damaged, you will have numbness in that dermatomal distribution, those strips that you saw in the cartoon that we saw, and into the different muscles where the nerve goes to, and it can cause a lot of weakness. Okay, next slide, please. Okay, so that's the background, and that's going to be a majority of the talk because the nerve conduction studies in EMG are, again, just an extension of the clinical exam. Now, we use machines that look like this to do the nerve and muscle testing. And the proper approach is that the clinician knows what diagnosis he is looking for and has a hypothesis which he's testing. He will either test the hypothesis or refute the hypothesis, and he really shouldn't get into any surprises. It's not the type of test where somebody will come into a doctor's office and just test the patient and just come up with a diagnosis like that. But what we're seeing lately, and you know, the laws are in the process of being changed to not allow this anyhow, is the nerve part of the test being done without the needle part of the test and coming up with random diagnoses that the internist, who may or may not know better because it's not his specialty, will be convinced that the patient has this. And really, the makers of the machines or unscrupulous doctors and the businessmen are really taking advantage of this. So that you will see that people go into different doctors' offices and perform tests randomly on the patients. And what they'll do is give various diagnoses and give it back to the internist, and that's sort of his problem. Anyway, I'm diverging from this. This is how the machine looks like. Okay, on the computer screen, the waveforms will show up. There's wires that come out of the machine, and they're attached to different parts of the arms and legs usually. The nerve is stimulated by a small shock. Okay, it's sort of like if you put your finger in a light bulb socket or that sort of feeling. So that it is a little bit painful. Okay, and what happens is you stimulate the nerve. The nerve gives off a nerve signal that goes up or down the arm or leg. The next slide, please. And this is an example of what it may look like. There will be the other leads will record the nerve signal at a different part of where the nerve goes to. Okay. Now this is an example that is probably stimulating somewhere in the forearm and then recording in the hand. But it's an unusual technique, which I'm not sure exactly what it's looking for, but this is to illustrate one example of what the leads may look like. Next slide, please. This is a cartoon of what the waveforms will look like on the machine. Okay, in this example looks like a motor nerve conduction study where the sticker or the recording electrodes are placed over a muscle, and the stimulating electrode is placed over a nerve that the practitioner knows goes to that muscle. When the nerve is shocked, the muscle contracts, and they record the signal that goes to the muscle. Next slide. Okay, this is a pretty close example of what my particular machine looks like. Okay, what has happened in this case is there is a muscle group on the foot that is stimulated. First they stimulate at the ankle, then they stimulate behind the knee. The ankle stimulation gives off the nerve signal at the top of the screen. Behind the knee gives the second part of the screen, and then different aspects of the waveforms are analyzed. How high, basically they're looking at how high or how large the response is, and how quickly the response appears, and what they actually do is they subtract the time that it takes the second response to appear from the first response to appear. They measure the distance in between and divide that, and then you calculate a very simple calculation for a nerve conduction velocity. Next slide. And this is an example of different aspects of the waveform that are looked at. Okay, next slide, please. This is also an example of a special technique for myasthenia gravis, where the nerve is repetitively stimulated, and if the patient has the disease, which it appears in this form, the second responses and third and fourth especially and beyond are much less than the first response. This is a special technique, and again, one should never do something like this unless he's already suspecting a condition like that. Okay, so Now the second part of the test is the EMG. It is the actual EMG part of the EMG test, where a thin needle is inserted into various muscles. I think that's the last slide. Let me just go to the next slide. Okay, now what else? Okay, now go back to the one where I show the arm, pretty near the beginning. The further back. This is about the third or fourth slide. One more. One more. Okay. Now, what I think this is the best picture to show it. You can see how the nerve goes into different. It runs through the entire arm. Now, what the neurologist would do is that he would insert the needle into different muscles along the course of the nerve. He will select muscles that he knows are innervated by certain patterns. For example, the deltoid is innervated by the C5 and the C6 root. If he finds an abnormality in the deltoid, it could be a C5 root or a C6 root, or it could be something more peripheral like a top part of the plexus. So he may pick the pronator teres, which is innervated by C6 and C7, okay? And you can see by different combinations of muscles, then there may be another muscle that he picks, might be C8 and C7, but not C6. So then by selecting a different combination of muscles, he can know exactly where the problem is coming from. In someone who does nerve conduction studies without doing the needle part of the exam, he just finds an abnormality in a nerve in the finger. You could see from looking at this that any abnormality from the neck all the way down the course of the finger can cause an abnormality in the response. Whereas the nerve part, he can go a little closer to the shoulder, a little closer to the hand, and select the right muscles for the thing. So what the needle actually has, so the needle pierces the skin and it inserts inside the muscle, the needle actually, to me, it's always really interesting, the needle actually has an electrical sensor at the tip of the needle. And the muscles and the nerves release electricity when they contract or when they activate. So what all the machine does is it picks up the signal and it's interpreted as normal or abnormal. So the different patterns that are used allow the neurologist or whatever other specialty is doing it to do the test. So, this is just a basic overview of the test, and you can see that it's very easy to, I think it's very easy to see that the test, if it's done properly, can be complex, but the proper way to do this is to reduce all the different possibilities by knowing the patient and going back to the patient and giving a relevant diagnosis to how the test should be used. Okay, so that's the basic overview, and that's the end of my talk. Thank you very much.
As a neurologist, I push to have this done by neurologists because the test has fallen into the hands, and I don't want to denigrate physiatrists, but physiatrists have been doing this test, and I don't think the test should be done as an extension of the neurological exam unless it's done by a neurologist. That's my basic view on this particular test procedure. Before we ask for questions on these three speakers, Dr. Mazides is going to introduce Joel Goldstein, who's going to talk about Millstone Unturned, and he will give his introduction now.
Great, and we wouldn't be, after hearing all of these very nice and interesting talks as physicians, we don't forget that we are MDs, we wouldn't be complete without having the perspective of the patient. And from that perspective this evening, with these disorders as you're hearing, it can be pretty dramatic. We have Mr. Joel Goldstein. I'd like to invite him to come up. And he has a background, he's not a physician, but he has that scientific approach, scientific mind through his background in information technology, because he, as an interested parent, had to deal with his son's accident. And that accident generated a lot of issues, a lot of problems, many of which were dealt medically at New York University Medical Center with neurosurgery. But even beyond that, it went on to deal with the deficits that this boy had to contend with over many years, and how the parent now came in to identify support systems, to identify this as an issue that had to be dealt with and supported through the insurances. And that also, as you'll hear, had ramifications that relate to injuries that we have to deal with now through our forces coming back from theaters of war abroad. Joel.
Thank you, Dr. Mazides. And as he's already said, I'm here tonight because he invited me and because he's treating my son. At another level altogether, I'm here because one of Dr. Golfinos' colleagues, Dr. David Harder, a brilliant neurosurgeon, saved our son, it's roughly 10 years ago tonight, on an emergency basis. He was operated on, do or die without parental permission. We didn't know that Bart was hurt. So it's a small world and we're here, and I say and I give my warmest regards to Dr. Harder. My son and daughter were born in Korea. They're Koreans, and we brought them over here and adopted them. And we raised them Greek Orthodox. Don't let the name fool you. I'm Jewish. They were raised Greek Orthodox with a Jewish father and name. And they're not terribly confused about their identity. They're very ecumenical. The kids, Nunos lives in Kekara. We've been to Greece many times. And Catalaveno, Ligo Elenica, Ke Milaudigo, then Politola. I'm very good with food and drink, though. I don't mess up Ligo Classy with Ligi Bira. So, I'll try to be brief because I appreciate you've been sitting and they don't seem to give you a 7 innings stretch like in a Yankee game. Each decade, 500,000 Americans die and 2 million are disabled by TBI. These are astounding numbers, and just as astounding is the fact that there is no general hue and cry about it, about this staggering invisible epidemic. Brain injury is by far the leading cause of death and disability among young people. Everything else is dwarfed. We hope that Bart's story of tragic loss, grief, endurance, as well as triumphs, helps to put a human face on TBI. With our forthcoming book, No Stone Unturned, we hope to help build public awareness of this problem and to help launch a grassroots movement similar to autism awareness. The need is urgent because of, as Dr. Mazides mentioned, tens of thousands of wounded warriors are returning with this condition from the wars. Hemingway, in A Farewell to Arms, said that the world breaks us all. Then afterward, some are strong at the broken places. Faced with a parent's worst nightmare, a car accident resulting in our teenage child's traumatic brain injury, No Stone Unturned is foremost a family saga, a life-affirming, sometimes hilarious testament to what a family and a community can do. We share our breathless desperation when after a month in coma and 8 months of grueling hospital therapies, the verdict is in. The school district agrees with the hospital's assessment. Bart is not ready or suitable for placement back in a classroom. He'd be better off in a comfortable, safe setting like a nursing home. We railed against warehousing our 17-year-old son in a nursing home and fought time and again to win Bart the chance to struggle, heal, and make progress. We were determined to keep up the bar, to set attainable but difficult but attainable goals for Bart, and then raise the bar again and again. After all, who knows how far anyone can go? It takes a little faith. These bureaucrats are not so much mean-spirited as driven by statistical models of probable outcomes without taking into account the character of the boy or of his family. exploring unconventional therapies. 10 years later, thank God, with high school and even a semester of college under his belt, Bart is a lively, charming young man living practically independently in his own apartment in the Albany area, about an hour away from where we live. How different the outcome might have been had we heeded the advice of well-meaning, busy bureaucrats. If there is one universal truth about TBI, it's that survivors need strong advocates. In the family, each of us, wounded in our own way, mourns the boy lost in the crash, even as we struggle to relate to the stranger in our midst. We witness Bart's adoring little sister's bewilderment in the face of his wild mood swings and angry outbursts. We feel the everyday torment that survivors and families slog through. The bonds of love and duty are strained to the limits. A year into Bart's recovery, his losses remain staggering. And I'd like you to, because you don't know Bart, think of someone you know, some 17-year-old boy, your son or your nephew or the boy next door. Please imagine someone you know. He's still relearning, this is a year later, still relearning to walk with a proper gait, to use his right hand for writing and eating, to speak fluidly and sensibly. Once quick-witted and golden-tongued, his mumbled speech lacks spontaneity, subtlety, depth, or humor. Formally in accelerated math class, he's struggling to relearn the times tables. Odds-on favorite to win class clown, he no longer gets the point to simple jokes. Once a point guard for the high school, he can barely reach the hoop or dribble the ball. Our book recalls the first 4 years of Bart's recovery. It's peppered with love and laughter. We know the healing power of truth, of both. But for Bart, what he prized most in life is torn away. Friends, girlfriends, driving, athletics, being the life of the party. People sometimes ask me what TBI is like. I tell them imagine crippling paralysis coupled with wholesale loss of short-term memory and other cognitive functions. Add a dash of confusion and madness for good measure, making for a global injury that diminishes every aspect of life. It's tough for survivors to hold on to their zest for life in the face of those hard realities. When the brain's executive function is damaged, just getting up and dressed and out for the day may try one's very soul. Anyone with a brain injury understands that the enemy is fatigue and what comes in its wake, confusion. If brain fatigue weren't enough, survivors must contend with diminished inhibitions and reduced emotional control. This inhibition shows up as embarrassing, annoying behaviors calculated to drive friends away and drive family nuts. Living with a TBI survivor is like living with a jack-in-the-box. Crazy is always just a half turn away. While short-term memory is almost always impaired, long-term recall is often intact, making survivors painfully aware of what has been lost. This distinguishes TBI from congenital conditions like developmental disability and autism. It casts a gloomy, tragic shadow over the picture that slowly emerges for the survivor, who recalls often with deep longing his former life and abilities. Loved ones must deal with their own private torments. To this day, Bart's mom, who's here, suffers high anxiety riding in a car, even though she never saw the accident scene. His sister and he are yet to regain their old closeness, if they ever do. And I haven't slept well in 10 years. I seem to have lost the knack. We're each walking wounded in our own way. Years of therapy lay ahead. I'm going to skip this part. You know the therapies. Everything you can think of, especially cognitive therapies. And counseling. He had emenopsia, so vision therapy, you name it. For young adults, the loss of their circle of friends is a howling, grievous hurt. Bart's experience is typical. Just as the fog begins to lift and he needs them most, his friends are in the wind. Buddies get on with their lives, and the survivor, unable to keep up, is left behind. This is very tough on parents, by the way, to witness. It's a long, hard road back for survivors and families. No Stone Unturned, which will be out in a few months, is a thoughtful guidebook for survivors of severe TBI, unconventional therapies are not merely a reasonable option, they're a necessity. Best practices of conventional medicine only take us so far. They often end at the nursing home door, or if heavily medicated at home, driving families crazy. Sometimes I have a lot of friends, obviously, with TBI and their families. Sometimes I say, you know, the zombie craze, all the movies and stuff. We've got them. We've got millions of TBI survivors. We tried several unconventional therapies, guided always by the principle, do no harm. We tried hyperbaric oxygen, and at the time, most neurologists dismissed it as a waste of time. Today, HMOD is demonstrating great promise in a large-scale study the VA is conducting at its Texas Center, 1,000 vets, and is also part of the standard treatment throughout much of Europe. One should remain open and alert for emerging and unconventional approaches. Accepted wisdom holds that the window of opportunity for recovery from TBI closes after about a year, or maybe 2. Yet several years after his severe injury, Bart took part in a crucial experiment at Columbia University demonstrating the brain's plasticity, which also restored part of his field of vision. The hemianopsia was rolled back. I'm not here to advocate for a specific unconventional therapy, and mind you, Bart's remarkable recovery resulted from a combination of conventional medicine and unconventional and emerging therapies. It took him 2 extra years to graduate high school. He was a senior for 3 years. Gradually mainstreaming from special ed to regular classes, then a short abortive stint in college, followed by a couple of years of cognitive therapy. Thank God he's made new friends. We visit him every Sunday. We often go shopping together. We touch base, and we help keep him organized. He's looking for a part-time job. He had one. He was laid off. Of course, there's no royal road to recovery. It's slow, tortuous, backsliding, unpredictable. Just when you think you can relax, Jack springs out of the box. Bart seems pretty normal, but still suffers from unseen injuries. Today, if you saw him here, if he was here, he'd say he's going for baklava, but he'll come back with spanakopita. He misplaces his cell phone more often than others. He needs our continuing involvement in his life in a way probably not typical of 26-year-olds. Impulse, he told me if he ever laid hands on a bundle, he'd go to Vegas and blow the whole thing. I'm sure he would. Now, 10 years later, he is once again a very funny guy, thank God. Why did we succeed to the extent that we did? Well, first, we had a very fine EMT on the site immediately, intubated Bart, and medevaced him. We had a brilliant neurosurgeon, David Harder. Beyond that, we refused to give up. We left no stone unturned. We thought outside the box. We tried everything as long as it would do no harm. A lot of it we were skunked. Harmless and useless. But others, like hyperbaric oxygen and craniosacral therapy and Boyle sensory learning and VRT, the vision restoration therapy, and supplementation a la Dr. Perlmutter, these did pay off. We did prayer that spanned the continents, all faiths. We even visited a stigmatic. Bart was blessed by the largest remnant of the True Cross in Kirkuk. We saw community support. We pushed hard to get him off the meds as soon as possible. They dumbed him down. We worked on a very long time horizon. Harder told us 6 months after the surgery that if we could put up with 6 or 7 years of hell, we could see Bart living independently. I'm grateful for that advice. He got cognitive therapy, and we're lucky that Bart is a sunny optimist. Just in closing, I want to say that survivors need strong advocates. Families also need support and counseling. Very often the other children are lost in the shuffle. We learned that later from our daughter. We need as a country to ramp up cognitive training therapy because it's mostly not available. Places like the Rusk Institute in Kessler, they need to make those best practices available. We need more neuropsychs. We need community support and grassroots organizations like Autism Awareness. The ancient Greeks counseled, count no man lucky until he's dead. Every family is but a heartbeat away from tragedy. Statistically speaking, chances are that 2 or 3 of us here will be crushed by TBI. We're all brothers and sisters in this struggle. If anyone knows new or emerging treatments for TBI, please see me afterwards. We're still searching, still open-minded, still fighting. deciding that DBI was. For your part, I brought a list of additional resources besides the book. Books, but mostly web pages that are really terrific, depending upon what you're interested in. If you're interested in veterans, there's an organization that's wonderful called Remind.org. It's Bob and Lee Woodruff's Family Foundation. They're great. You're going to see these patients. You may not see them for their TBI. You'll see them for whatever they present to you. But you can help them by steering them in the direction of some of these some of these groups are just support groups, others are research groups, and so on. And I thank you very much again for this opportunity.
Joel, this is a very moving story, and I commend you for bringing attention to this condition. But from my point of view, I think most importantly, it's a testament to the plasticity of the nervous system and how it can adapt to injury. And I think if you have stick-to-itiveness and push a patient, whether it's from traumatic injury to the brain or from a stroke, you can retrain people. And I think you should be commended for bringing your son to this level of recovery. Now, for all people here and the lectures that we've had, we welcome questions for the three speakers, or the four speakers, including Joel. Anybody have any specific questions for these speakers? Yes.
Can I ask you also for opinions?
I'm sorry.
Not all these cases of neurofibromatosis type 2, they are, malignant tumors starting. So in case that they start as benign fibromas, how much alert you should be, and what you should do actually to follow them up to avoid missing any early
Yes,
transformation to cancer.
Right, so the good news is, again, as I said,
Genetic studies and plus, how long
so the genetic studies don't help you in terms of malignant degeneration. The only way you can do it is through close follow-up. So it's really annual MRI scans. And the ones that you have to worry about are the peripheral nerve tumors, because they tend to be larger, they can get to a large size, and that's when they undergo malignant degeneration. It's still a rare event. But when you see somebody that has a big, painful peripheral nerve tumor, that's the one you have to follow closely. And generally, these are tumors that grow so slowly that they go years without a demonstrable change in size. They're only growing a millimeter, 2 millimeters at a time. And then as you start to see rapid growth, that's when you have to worry about malignant. There's no other way to do it. There's no other way to predict who's going to get a malignant degeneration in NF2.
Yes.
And can I ask Dr. Daras for something else also?
Well, since he's got the mic, I just want to ask him a question. What is the overall life expectancy of these?
So it all depends on the age that you're born with. If you get it as a child, then very few make it into their fifth decade. As an adult, we have patients who are in their 70s and 80s and still doing well.
Yeah. Yeah, what he has in mind.
You showed us a couple of images, I think there were sagittal images that had lesions in the spinal cord, and I was wondering, were those oligodendrogliomas, angiomas? I mean,
yes, the answer is yes. So there are ependymomas, low-grade gliomas that are not ependymomas, you name it, and it can be there.
So non-neural crest.
Well, presumably they all start out, right? I mean, astrocytes, glial, any glial tumor, any glial cell starts basically at the neural crest.
Okay.
Yes.
Yeah, Mike,
Dr. Dara?
the optic neuromyelitis, it's a rare disease autoimmune. So is describing children age, childhood at all?
It has been described in children as well, but not very commonly, as most of these autoimmune CNS disorders are not common, but it has been described in children. By the way, I want to make a comment to Dr. Golfinus. You mentioned about neurofibromatosis 1, 2, and you mentioned about schwannomatosis. The best example of hereditary schwannomatosis is observed in the damselfish that is in Florida.
Are they edible?
They look so colorful that probably are not edible.
I have a question. Most of us here are probably not neurologists or neurosurgeons. Some of us are doctors who get questions from all fields. Some of us are one sentence, if you could give us something to take away, whether you're a physician who can deal with anything as it arrives, or a parent, or a patient who gets a symptom, what are some of the keys that you would want us to come away with? For example, Dr. Gofino, for example, here's what I want you guys to come away with. If a patient who develops sudden loss of hearing, take it very seriously. It could be a tumor. How fast you resect it? Give them steroids, whatever. What can you get us to come away with? Same thing with the neuritis or optical problem, and maybe even an EMG. Because, for example, in Dimitri, you're talking about EMGs. You know, it's all said and good, but I'm curious. What is a good example of, hey guys, you want to save someone, you want to do good medicine, this person needs an EMG. If a person's in a traumatic injury, this is a TBI hint that you should take seriously. So can you give the parents, the primary care doctors, the people in this room, maybe something to come away with that is useful in life, not just in medicine?
So I love this question.
But that's a whole symposium.
It really is. And I'll try and give you just two things, I think. So I love the question because we have such a perverted point of view. We see everyone else's mistakes, right? We see every headache that did turn out to be a brain tumor, not the 995 that did not turn out to be brain tumors, right? So what is one thing you can take away? Now, first of all, NF1, neurofibromatosis type 1, is now almost always diagnosed at birth and should be by the neonatologist, just by looking at the skin findings. So and every child gets an exam now, so most of those are now found very early. NF2 is still very hard to diagnose, but any child that loses hearing early on, that's not normal. What I always see are patients in their 30s and 40s who are told that their hearing loss is just regular aging. So if you lose hearing on only one side, that is not regular hearing loss. That's not age-related hearing loss. Think about it. Both of your ears age at the same rate, unless you shoot a gun or unless you have noise exposure on one side. So unilateral hearing loss has to be investigated. And you even see some ENT physicians still make the mistake, where they get the audiogram, they see that the hearing's gone on one side, it has all the hallmarks of a nerve problem, and they still say it's age-related hearing loss. It's not. So as a primary care physician or an ENT, if you see single-side hearing loss, and especially in anybody under the age of 70, you really need to investigate them. That's probably not going to be regular old hearing loss.
Mike, address that.
I mean, in the subject that I just mentioned, as well as other subjects, when we see something so aggressive like loss of vision, okay, this should be addressed as soon as possible. I mean, whenever you see something like this, or you see somebody developing paralysis, weakness of the legs, suddenly, I mean, you get on the phone, you get your friend neurologist, and tell him, I have a case such and such and such, and you better see him right away. I mean, there is no other way dealing with patients of neuromyelitis optica or any other optic neuritis, because, I mean, when the symptoms first start, you don't know whether you're dealing with something extremely aggressive or something that you may wait a day or two. I think you should try to address it as soon as possible, and don't hesitate to call whoever your neurologist, the neurologist that you refer patients to, get him as soon as possible.
Your point?
All right, I think you may have heard me say it a couple times. The take-home point is that the EMG is an extension of the neurologic examination, okay? And just to, so that you can understand a couple quick examples why that is. A few times in my practice, I've had a patient who was seen by other physicians and had EMGs. I can distinctly remember an elderly lady who had back pain or buttocks pain radiating to the leg. She had an MRI that had a lot of disc bulges. She had an EMG performed by another physician that said that there was radiculopathies or pinched nerves, except no one did a good neurologic examination, and I suspected actually that there was a problem with the hip, and actually on both sides, although I did look at the MRI myself, there were some disc bulges. I did the EMG myself, but my EMG was normal. So, but that's when what I would have suspected during exam. I took an x-ray of the hip, and there was severe osteonecrosis of the right hip and the milder osteonecrosis of the left hip, although she was being sent for physical therapy for 2 years and said that she was getting worse every time she went to physical therapy. Now, every test in the world was done on her, but no one did an examination, and no one used the test with the approach as, this is what I think clinically, let me see if it fits now with my test, okay? And the other example is a young woman who had numbness in the 5th digit, okay? Any neurologist knows, and most other physicians know, that carpal tunnel syndrome does not affect the 5th digit. It's the only digit in the hand. The pinky is not affected by carpal tunnel syndrome. Yet they had a routine test that showed slowing of the median nerve across the wrist. And of course, she was diagnosed with carpal tunnel syndrome and had all kinds of treatments and everything. It's true, but irrelevant that she had slowing at the wrist. She did not have carpal tunnel syndrome, even though the test might have been interpreted that way in someone who did have the syndrome. So the test is an extension of the neurologic examination. Anybody, and please be careful of any test that is done by a physician, by some, what I'm seeing lately is technicians are sent to doctors' offices, and the test waveforms are being interpreted by a physician who has never seen the patient. That is completely inappropriate and dangerous, and it puts the physician who has these people coming to their offices at risk, because it's your test results, and it's not going to be good enough if somebody has, you could say, well, that's what he told me he had. So it has to be an extension of the exam, and it's the only way that it can properly be done.
Joel, take home point?
Well, I said I'd be brief, so I'll be very brief. TBI survivors is roughly 6 million disabled individuals, not counting mild TBIs. They're going to come into your practice, and they're going to have a rash or whatever it is they have. You want to see if, to the extent that you can intervene in their lives, see if you can help the caregiver, help the advocacy. We're starting a grassroots movement, and there are people who are doing work in this area. And as I say, I left a lead behind with resources. It's a very socially isolating situation. The person is isolated because they can't get out and about, nor can the family to some extent. If you can help push them in that direction, you'd be doing them a great kindness.
Thank you, gentlemen. My take-home point is very simple. The patient who presents with any symptom referable to any part of the nervous system or organ system in the body, the paramount point that I would like to make is that the examination by a clinician is the most important part in making the diagnosis. Not the MRI, not the EMG, and not any other technology test. Today, young people who graduate from medical school, they see a patient with back pain, oh, go get an MRI without even examining the patient. And I think that's wrong. And I think the examination is still the most important part, certainly from the neurologist's point of view, part of the clinical evaluation of the patient. Any other questions? Yes.
Yeah, I have a question. I'm very lucky that I'm here today with all of you neurologists, years ago, I was diagnosed with tinnitus, and I almost reached the point of committing suicide as a result of that. I was able to fight it to the point that I now have
interprets the missing information from the hand as painful, so that they still feel that their hand hurts even though there's no hand there. Same thing with tinnitus. It arises usually from some type of hearing loss, whether it's Meniere's disease or something related to that, most commonly Meniere's. Tinnitus also happens in all of us as we lose hearing as we get older. And again, it's the brain replacing the lost information. That's all that tinnitus is. It's a phantom noise created by your brain. What can you do about it? So in the old days, the thought was, well, maybe we can get some noise back in there and that'll fix it. But you have to code it exactly the way the nervous system is waiting to get it. And that's incredibly difficult to do. But there are new techniques, and new stuff comes out every year. William Shatner, the guy who played Captain Kirk, is a famous sufferer from tinnitus, and he's been behind a lot of the groups that have pushed new ways to do this. So distraction techniques is one thing, white noise generators, and then all these other new techniques. And I can tell you that every year they're going to find new ways to stimulate the remaining cochlear nerve that's still working, and that'll do it. The latest is a trial of actually putting stimulators over the brain areas that interpret sound. It's a drastic step. You have to open the skull. You have to put the stimulating pad in the epidural space. But that's one of the things they're doing. So the next phase is trying to stimulate the brain itself to remove the tinnitus.
One more question.
What is the recurrence risk of the neurofibromatosis type 2?
How common is it?
Recurrence risk.
The
Recurrence risk.
Well, the recurrence risk. Well, they always develop new tumors. Always. They're always constantly developing new tumors. It's 100% recurrence.
Constantly you have to be alert to.
Yeah.
Thank you very much for coming, and for your time. The program is not over. We still have.
We're now going to be giving the scholarship awards. I'd like to have Dr. Michelis and Dr. McDavid join us. And then, of course, we have Dr. Kimisis, who's going to address us on his paper. But that's after the scholarship awards.
Thank you very much, Nick. Keeping in line with some of the remarks that Dr. Matsides made at the onset, what we're going to be doing now is presenting awards and scholarships. I'm going to be doing the awards segment, and these awards are named for actually founders of this society. So, as he mentioned earlier, people who had set aside legacies or donations to create either fellowships or these types of awards. If people are considering this kind of activity, you can see from what we're doing at this juncture, that this is a very useful and very valuable way to advance the goals of the society, which, as he so well put, was to advance medical work, to develop interest in the field of medicine, and even at the high school level to get people who might be contemplating a career more interested. So the awards that I'm going to be giving are named for Dr. Lanzunas, who is a well-known orthopedic surgeon, Dr. Molinas, who is a well-known pharmacologist, and Dr. Christos Bozis, who practiced medicine. And all three of these gentlemen were actually founding members. So with the 75 years that we have now, these are people that were in at the foundation of the society. Their names, their efforts, and their legacy actually continues. The first awards we're giving are the Lanzunas Awards. I also want to mention, before I do give them, that we have a committee. You'll notice as these awards are given, you won't know all the details, but actually one of the awardees is from a part of Greece where I have several relatives that come from that area. One of them comes from my high school, another comes from my medical school, and that individual also has a name very similar to mine. So I want you to know that there is a committee that works on these awards, and that is Dr. Iliadis, that's Dr. Nick Robotis, Dr. Nick Romas, my good friend Dr. Paul Zavatakis, and the final arbitrator of that award is, of course, Dr. Matsides, and on our committee for 7 years has been Dr. George Dangus. So we have a group that gets into looking at all these applications and then makes these final decisions. So what I'm going to do is start off with the Lanzunas Awards. These are given to physicians who are actively involved in research projects. And what we're going to do, first of all, is I'm going to get my list. Saris. She's from the University of Medicine and Dentistry of New Jersey in Newark. Her work actually to continue our orientation toward the central nervous system was on microRNA-mediated regulation of synuclein, and this has to do with toxic accumulation of proteins actually in Parkinson's disease. So we'd like to congratulate Christina Saris for her research work. Next Lanzunas Award, again, has to do with central nervous system dysfunction to a degree. This is Anastasios Maurisis, and Anastasios' work is in the role of AKT protein kinase in depression, and Dr. Maurisis is doing this work actually at NYU School of Medicine here in New York. Next, the awards are to people, again, in medicine, actually in medical school. One of them is actually past medical school, but the first one on the list is at George Washington University. Her work, her essay was written on the Mediterranean diet. We deviated a little bit from the neurologic orientation to cardiovascular disease, and actually it's going to be similar to the second awardee in this category too. And I'd like to congratulate Dr. Catherine McKellis, or soon-to-be Dr. Catherine McKellis. And the second Molinas Award, which again is a scientific essay, is a distinguished scholar in the area. This is Dr. Mikhail Papafaklis. Dr. Papafaklis is actually from Yanina. He got his medical degree and PhD there. He's actually doing PhD work now at Brigham and Women's in Massachusetts, and he's looking at the effects of endothelial shear stress on the degenerative changes that happen to the vascular tree, particularly related to coronary artery disease. Dr. Papafaklis. So those are the research and the essay grants, and the last category are the BOSIS Awards, and these are essays given to individuals in high school. And the first, Domino, who also looked at a nervous system project and also had an essay related to the development of depression, and she's from Garden City High School in Garden City, Long Island. Second one is Athena Lascaris. And Athena comes from Brooklyn, New York, and actually comes from Fort Hamilton High School, which I'm a proud graduate of as well. And she wrote an essay having to do with some of her own experiences, having to do with physical medicine and rehabilitation, which is somewhat along the lines of the dramatic story that we heard tonight. Athena Lascaris. Christos Mouzakitis, and Christos also was in the cardiovascular range when he wrote his essay on the effects of omega-3 fatty acids on the treatment of heart disease, and looked into the pluses and minuses of various remedies which are said to contain or not to contain omega-3, and wrote a great essay on that subject. Christos, by the way, is from the Bronside School of Science.
Show our support, and we just ask in return not to turn their back on us and be, involved in the society. I think this is a great society. We tie in education, we tie in our culture, we tie in medicine. So it really is a wonderful organization. Obviously, I don't sound like I'm retiring, but I'm not. I'm just not going to doing scholarship. But anyway, I want to thank my committee members, and the one person by far who does so much work for our society in every aspect is Evangelia. So I'd like to just say thank you, Evangelia. Okay, we had to narrow down our recipients down to 2 this year, and both of them, believe it or not, come from the New York College of Osteopathic Medicine. And I'll introduce them one by one. The first one will be Paul Petrakos. Is he here? Yes, come on up. And last but not least, Kostas Stavrakis. Is he here today? Great, thank you. Thank you very much. Nick, give you the microphone.
Thank you very much. I also have to congratulate Theo on an excellent job. It takes a lot of patience. And obviously, we all follow in the steps of those before us. So as you'll see, you heard this evening, and you'll hear again tomorrow for those of you there, the achievements of the members and their contributions in order to get to this point. And we're looking forward to many more applicants and more scholarships next year, and of course the fellowship there with Dr. Chang at Columbia University, which we're looking forward to. Now I would like to invite, we're getting a little late, Dr. Kimisis to join us. Dr. Kimisis is our Distinguished Colleague Award recipient this year. He's an esteemed colleague, psychiatrist in practice in New York, who also is very active with support for Cyprus, where his background is from. And he's going to tell us about this initiative to found a private medical school of caliber in conjunction with St. George's University London, and collaboration also with Israel, as we'll hear.
Thanks, Nick, a lot. I know it's getting late. I'm going to be very brief. But I just want you to know that it has been a dream in Cyprus to have a medical school. There have been many attempts, and many people have been trying, but finally it is a reality. I don't want to take the credit for this. It has been a lot